Thank you, Val. Alrighty, welcome back to everybody that has joined us for our previous webinars today. Welcome as you stream into our webinar. This is the Washington Academy of General Dentistry Stay Home, Stay Healthy CE series. Just a reminder that this series is being brought to you as a courtesy as part of your AGD membership. We'd like to thank our Executive Director, Valerie Bartoli from the Washington Academy of General Dentistry, and our panelist, Dr. Gary Hayamoto, for helping out. Also, thank you to Dr. Pressett for his work on the webinar and getting these webinars up on there as soon as we get the flyers created. We've had wonderful support from our presenters, our doctors, you name it. Thank you very much for those that have volunteered their time. For those of you that are non-AGD members, we will be issuing CE for you. We're doing that through the University of Washington School of Dentistry Continuing Education Department. We'd like to thank our other co-sponsors, the Canadian Academy of Restorative Dentistry and Prosthodontics. We'd like to thank Pierce County Dental Society, Snohomish County Dental Society, and Seattle-King County Dental Society. Also, we'd like to thank Comet USA and Patterson for their support of this series as well. You will notice there's flyers going by with upcoming webinars. Please feel free to use the QR code to get you to the registration. If you notice that a flyer does not have a QR code, we just have not got that up on our website yet, and the registration information, we're working on that. The best place to stay in contact with us is actually Facebook. On Facebook, if you go to Washington Academy of General Dentistry, you'll find our Facebook page, and we post the events there, and there will be links there to quickly register for upcoming CE events. So I'd like to thank all the students from the University of Washington School of Dentistry, student chapter of the Academy of General Dentistry for joining us as well. We look forward to hosting the 2020 Howard competition on Friday. This Friday we have 4 of our students doing presentations of about 15 minutes. And there will be a registration for that if you're looking for additional CE. We're also going to have our Master Track presentation. So we'll have some of the participants from our Master Track program of the WAGD doing presentations as well. This is one of the ways, if you're trying to get your master's in the Academy of General Dentistry, you can get those CE credits by doing presentations in the different subject codes. We've got a few more minutes here before we're scheduled to start, and we've got over 1,000 people registered for a perio classification lecture. So that is absolutely fantastic, and I'm pleased that you're all here to hear Dr. Michael Giardino speak. I've seen this lectured before, and I think he does a great job putting this into perspective, the new classification system. This is one you want your hygienist to see and your front desk as well. Here's the issue. If they're not logged on right now and registered, it'll probably take them a little bit of time to do that, but you can have them watch this webinar on YouTube after the fact. We'll have this up on YouTube within maybe 3-4 hours, or just check back tomorrow. On YouTube, where do you go to? Well, type in Washington Academy of General Dentistry, and that'll take you to our YouTube page. When you're there, please like, subscribe, and hit the bell so you're notified every time there's a new webinar uploaded to that site. Right now, I think we've got about 20 different webinars and other content on there. Today, Michael Fling did just a wonderful job with his presentation, and we're going to likely bring him back on Monday. So for those of you that saw Dr. Fling this morning, we'll be bringing him back. Hopefully we can nail down the time on Monday. He'll be going over his shell technique that there was so many questions about. Dr. Ross Nash, that's Deborah's husband, obviously. He's presenting on Monday on indirect aesthetic dentistry. So that's going to be a good one. Again, you're logged in, you're watching the Washington Academy of General Dentistry Stay Home, Stay Healthy CE series, brought to you by the University of Washington School of Dentistry CE. The University of Washington will be providing your CE credit that will come to the email you registered at over to get signed up for this webinar. Do not expect that CE instantly after this presentation. It's going to take a couple of days. Today, if you have questions, please use the Q&A function, that feature on your Zoom. Do not use the chat feature. We will keep the chat for just side comments, etc. But if you have a question that you want Dr. Giardino to answer, let's put it in the Q&A. I believe we have the vote function supported in this webinar. So if you see a question you like, just upvote on that in that Q&A. We want to thank the Arkansas Academy of General Dentistry for joining us, the California Academy of General Dentistry, and Texas as well. Thank you to all our friends in Canada, the Canadian Academy of Restorative Dentistry and Prosthodontics. May 7th, Thursday, May 7th, we've got 3 speakers from Card P that are going to present to us. We've got Dr. Kim Parlett going to be speaking about occlusion. We've got Mark Douglas, who is going to speak about implant provisionalization using the extracted tooth. And we've got Ian Tester that is going to tackle the tough age-old question about, or debate about centric relation versus reference position. So those should be good presentations. We are also looking forward to our International Academy of Nathology Day, and that should be May 4th. We're just finishing lining up our speakers. And we're looking forward to Dr. Kenton Ross and the Arkansas Academy of General Dentistry, the speakers they're putting together. So thank you again to all our sponsors. We're about 2 minutes in here. I can see the numbers are still clicking in pretty quick here. So we'll just take a minute or so. Do yourself a favor, play around with your interface here on the Zoom. You're not going to hurt it. You can change from gallery view to speaker view, etc. If you have questions, those questions will go in the Q&A section, please, okay? CE credit, again, will be emailed to you at the email address you registered at. For those AGD members, you will be credited automatically by us. We'll submit your CE credit to the AGD, and that should show up on your transcript within 2 to 4 weeks. So be patient with that. And just a reminder, we've got some great webinars coming up. Use the QR codes that are available on the flyers. If you don't see a QR code on the flyers that are going by, that means we just haven't got the registration information up and ready to go yet. We should have that updated here in the next 12 to 24 hours. So please check back. If you miss using one of the QR codes, simply go to www.washingtonagd.org. You're going to see some of these webinars have already been completed. We just wanted to leave them up so you could see who we've had speaking. We've just had such great support all of those webinars right now will go up on YouTube and will be available for a period of time. Unfortunately, we cannot issue CE credit for you watching it after the fact as a webinar on YouTube, but please share those webinars with your staff members and your colleagues. We appreciate it. Again, anybody is welcome to attend these CE events, so please share. And with that, it looks like we're almost maxing out on our participants here, so that's terrific. It gives me great pleasure to introduce Michael Giardino. He's a third-year resident at the Graduate Periodontics Joint Certificate MSD program at the University of Washington School of Dentistry. He grew up in Spokane, Washington, and obtained his BS and DDS from the University of Washington. Upon graduation, he entered practice in Seattle and practiced for 5 years before returning to UW for the full-time residency program. His research includes work on antibiotic resistance in bacteria, and he is currently pursuing research on biofilm formation. He plans to practice in Spokane, Washington. Dr. Giardino, thank you very much, sir. It's very kind of you to donate your time. I was wondering if you could just do one thing before you get rolling. Tell us a little bit, how are things at the university right now? What's happening?
Yeah, well, first of all, Dr. Hess, thank you for inviting me, and thanks everyone for joining us. Well, obviously it's a little bit of a tough time. We have not been doing routine patient care for several weeks now, obviously. We're not really sure exactly when we'll be back to routine. We do have protocols in place to see our emergencies. But just like, you know, most of the other practitioners out in the state, we are just following the order by Governor Inslee, and just kind of gonna wait this out and see what happens.
So a lot of time to work on research projects.
Yes, lots of time for that, and lots of time to read papers and all those types of things.
Excellent. Well, again, thank you very much for doing this. I sure enjoyed it the first time I saw it in the Perio-Pros seminar series there. So please share your screen, and I'm going to mute myself unless you need me.
Okay. Okay. So good afternoon, and thanks for the introduction, Dr. Hess. I want to thank you for inviting me, and I want to mention that I'm very honored to be a part of this series with so many amazing other speakers that I've been enjoying. So in the residency program at UW, we meet 4 days a week for an interdisciplinary treatment seminar. So residents from GPR, ortho, perio, pros, and endodontic programs present clinical cases, and we lecture on relevant topics. There's a strong focus on interdisciplinary communication between the specialties and between restorative dentistry. Also with treatment planning and management of the treatment over the course of patient care. We always make an effort to use the terminology and the classifications that are supported by the most recent evidence. So I originally presented this topic because of the challenges that as perio residents we had integrating the latest classification from the American Academy of Periodontology when we present these seminars. There's been some criticism of the new staging and grading system, and often there would be debate on the proper application of the new classification. I was initially highly skeptical about the utility of staging and grading for a disease like periodontitis. However, I do think that there are some very nice things we can take from the updated system, particularly to identify those patients who might not respond as well as others to standard periodontal therapy. I think if all clinicians can use standardized terminology and classification, then we can provide better care. Dr. Hess mentioned I practiced in Seattle for 5 years. This is a picture of the building that I worked in. I took over a dental practice in this building, which is 2 blocks from the main campus of University of Washington. You know, briefly, we drew people from all over the world with a whole variety of dental backgrounds. It was very challenging diagnosing and treating periodontitis in these populations. I was commonly faced with giving a patient a periodontal diagnosis and treatment plan that was very unfamiliar to them. Some had never had prophylaxis or oral hygiene instruction with toothbrush and floss. Others had been supervised by a dentist and hygienist for most of their life, but they were presenting to me as a periodontitis patient or having unmanaged mucogingival deformities like gingival recession. I also had many dental implant patients in my care. I faced the challenge of maintaining those patients as well. So I mention this because periodontal disease is so common, it affects so many people. In some parts of the world, it's almost accepted as a part of life to have periodontal disease destruction. So it brings up the concept of what's disease, what's normal, how can we best practice so that our patients will complete our recommended treatment, and then what's the best way that we can stop the periodontal disease. So I'm going to first discuss some of the background concepts we'll need to be familiar with. Then I'll cover the previous two AAP periodontal disease classifications, and they are going to set the tone for how classification has been taught and used in research and clinical practice. Next, I will introduce the proposals from the most recent World Workshop of American Academy of Perio and European Federation of Perio from 2017. And we'll apply these classifications to some actual cases, and then I'll discuss some limitations and advantages of various classification systems. So some of the terms that we want to start out thinking in terms of thinking like epidemiologists, we want to define what a disease is. So it's a pathologic condition that presents a group of clinical signs that are peculiar to it, and they are different from normal or other pathological conditions. So a disease can be on a spectrum of severity, but it differs from normal aging or physical injury. In addition, it should have a unique variation to be considered a separate disease. When we make a diagnosis, we are determining the nature, location, and cause of the disease or disorder. So diagnosis is essential to treating the disease. Classifications, on the other hand, are slightly different. They have the goal of making a standard case definition that all patients can be fit into one of those categories, so that studies can be compared and interpreted with more ease. So this brings up the concept of specificity and sensitivity. With the diagnosis, you really don't want to have actual disease and mistakenly think the patient's healthy. This means you really want to have high sensitivity. In a classification, the opposite is true. A high specificity is most important. This ensures that no healthy patient is categorized as a disease, because then this would reduce the quality of your research data. Risk factor is an environmental, behavioral, or biologic factor that increases the likelihood of developing disease. For periodontal disease, we would consider smoking, diabetes, and certain pathogenic bacteria as risk factors. Whereas a health determinant is an underlying characteristic that shapes the health of an individual. So one of the most common health determinants, especially here, is going to be age. Gingivitis, as we know, is inflammation of the gingiva. Chronic periodontitis is defined as an infectious disease resulting in inflammation, progressive attachment, and bone loss, and characterized by pocket formation and/or gingival recession. It's the most common form of periodontitis, and it is prevalent in adults, but it can occur at every age. The disease is usually associated with plaque and calculus, and progression of attachment loss usually occurs slowly, but periods of rapid progression can occur. This is often associated with a variable microbial pattern. Recession is simply the migration of marginal soft tissue to a point apical to the cemento-enamel junction, or the platform of a dental implant. Lack of attached gingiva or lack of keratinized gingiva can present for several reasons, and it has an effect on the ability of tissues to create a barrier seal over the tooth or implant and to accept adequate oral hygiene. In addition, numerous clinical studies point to the lack of attached gingiva as a risk factor for ongoing attachment loss in the form of recession. Aggressive periodontitis is defined as a type of periodontal disease with rapid attachment loss and bone destruction in patients who are otherwise clinically healthy. Typically, there's familial aggregation and a younger age of onset than seen in chronic periodontitis. There may be secondary features like increased proportions of pathogenic bacteria such as AAP gingivalis. There can be phagocyte abnormalities, and plaque that is inconsistent with the severity of tissue destruction. Oftentimes, the progression of attachment loss can be self-arresting, which we might describe as a burned out case, where there was a lot of attachment loss, but it is no longer progressing. And our modern understanding of periodontitis, coming from the Darbo lab at UW, involves a polymicrobial disruption of host homeostasis. So not a single bacteria and not just the host response is responsible for the disease. It has to do with the interplay between both of those factors. It makes the disease very complex. Okay, so I'm going to start with some just review of the basic anatomy, progressing from health to periodontitis. In the health picture on the far left, you'll notice shallow gingival sulcus and apical termination of the junctional epithelium at the CEJ. In the gingivitis picture, we see a shallow periodontal pocket start to form. We see apical termination of the junctional epithelium still at the CEJ, but we also note inflamed connective tissue. In the periodontitis picture, we notice a deepened periodontal pocket, loss of connective tissue attachment and bone, and junctional epithelium on the root surface, and an inflamed connective tissue. Probing depth, also referred to as PD, is the distance from the gingival margin to the base of the probable crevice. It's the approximation of a periodontal pocket. The clinical attachment level, or CAL, is the distance from the CEJ to the base of the probable crevice. It's the clinical approximation of the loss of clinical attachment from the root surface. Periodontal probing is subject to some error. One of the main variables that influences how accurately periodontal probes measure the level of connective tissue attachment is the inflammatory status of the site. In inflamed sites, the probe will encounter little resistance from the connective tissue, and it will frequently come to rest apical to the attachment, meaning below the connective tissue attachment at the level of bone. Probes give us a good approximation of the actual connective tissue attachment level, usually within a millimeter. This slide shows two clinical situations. In the picture on the left, there's gingival recession and the CEJ is clearly visible. It's relatively easy to measure CAL by adding the probing depth measurement to the amount of recession. In the picture on the right, the gingival margin is coronal to the CEJ. So we have to find the CEJ using tactile sensation, and then we actually have to subtract from the excess gingiva to determine what the clinical attachment loss is. The detection of the CEJ can make this very challenging. As noted in the slide, redness and swelling are often found at sites with gingival inflammation. Adjacent non-inflamed keratinized gingiva demonstrates the normal color for this patient. And we also see purulent exudate, known as pus, suppuration, that can be expressed from the periodontal pockets just by putting pressure under the site. Bleeding on probing is a common finding in chronic periodontitis. It occurs because the epithelial lining is thin and ulcerated, so the probes breach the pocket wall and disrupt the fragile blood vessels. Bleeding on probing can occur at sites with gingivitis. It can also occur at a healthy site if an excessive force is used. After our periodontal probing and our periodontal exam, this periodontogram shows a lot of the relevant clinical information we've gathered. We display missing teeth, and we display malposition of the existing teeth if they drifted. We have pulpal status, mobility, presence of furcations, and we chart our existing restorations in endodontically treated teeth. We map the position of the soft tissue as well as the position of the attachment. And then plaque is noted with blue dots, bleeding and probing with red dots. So evaluation of the radiographic bone loss is accomplished with the vertical bite wings and periapical films from a current full mouth series. It's very important to note that past radiographs are extremely helpful in identifying pre-disease bone heights and evaluating the extent of disease and the speed of progression. For an implant, peri-implant bone levels, we need to look at past radiographs because we can see the level of bone at the day of implant placement, after the initial remodeling and integration and restoration, and the progression of bone levels over time. Intraoral photographs can provide an amazing amount of information about the patient, such as the periodontal phenotype, i.e. the thickness of the soft and hard tissues. Also the keratinized gingiva present at teeth. I took this photo with a digital SLR with a zoom lens and a ring flash with lip retractors, and we can use mirrors to provide additional views. But intraoral cameras that plug into a computer are inexpensive and very widely available and encouraged, particularly to document things like gum recession or aesthetic cases. As we all know, a thorough examination will allow us to identify the risk factors. With periodontitis, in the initial interview, we would specifically ask about smoking, diabetes, family history status, and if we see recession, about the history of orthodontic tooth movement or possible traumatic tooth brushing. Specifically smoking, we would like to know current level of smoke and previous. For diabetes, we'd like to know the A1C level so we can get an idea of whether the diabetes is well controlled or not. And family history status, because we see aggregation of periodontal disease, we would ask if our patients had severe perio disease in their family. So let's cover the previous two periodontal disease classifications from '89 and 1999, which set the tone for how classification has been taught and how it's been used in research. We'll also cover the ADA case type definition that's very commonly used by insurance companies. 1989 AAP workshop defined periodontitis as either prepubertal, juvenile with the option of localized or generalized, adult, rapidly progressive. Excuse me, there's a car outside. In 1999, the workshop changed some things around. I've drawn your attention to a couple areas. They define periodontitis as either chronic or aggressive, and a subset either localized or generalized. They defined recession as a developmental or acquired deformity, mucogingival deformity in the form of gingival recession in the facial or lingual or the interproximal surfaces. The periodontal disease diagnosis was further classified there based on extent and severity. Localized was greater than 30% sites. I'm sorry, localized was less than 30% of sites. Severity is involved with the amount of clinical attachment loss in millimeters. Now this is the ADA AAP joint classification that was designed just to try and have some good crosstalk between the different clinicians. And so we have gingivitis, we have 3 grades of advanced periodontitis, and then we have refractory and juvenile. So previously where we had aggressive periodontitis, now we're calling aggressive periodontitis juvenile periodontitis in this 1999 classification. One of the classic mucogingival categories is the Miller classification from 1 to 4. Class 1 is marginal tissue recession, which does not extend to the mucogingival junction. And there's no interdental periodontal attachment loss. In class 2, we have recession reaching to or beyond the mucogingival junction. But there is no interproximal loss. And so Miller put this classification together to give insight on whether or not we could predict coverage of the root with periodontal surgery. In class 1 and 2, we can expect predictable root coverage. Class 3 is recession extending to or beyond the mucogingival junction. And there is going to be interproximal bone loss. So our predictability of covering the root has gone much down. And class 4 is recession to or beyond the mucogingival junction, and there is extensive soft tissue and bone loss in the interdental area. So we will now move to the most recent classification. So in 2018, I was first-year perio resident, and I classified perio as chronic or aggressive, localized generalized, and mild, moderate, severe. Then I received this book in the mail. The process for which the World Workshop carries out their mission is commissioning a number of review papers, and then meeting in person to review the evidence and generate consensus statements by expert panels. Their goal was to update the 1999 classification based on the updated knowledge that we have about periodontitis, and to create a framework that we can adapt as our knowledge continues to expand. So the existing 1999 scheme was based on the current severity of the disease, so it does not capture how we got to that point. Not all individuals are equally susceptible to disease, and this is not found in the previous classification. And we think a new scheme could help flag non-responsive and high-risk patients. We also have a new classification of gingival recession that combines clinical parameters with characteristics of the exposed root surface. We've replaced periodontal biotype with phenotype. The term biologic width was replaced by supracrestal attached tissues. And traumatic occlusal force replaces the term excessive occlusal force. They also identified a new classification for peri-implant health, mucositis, and peri-implantitis. Edentulous ridge deficiencies are now called peri-implant hard and soft tissue deficiencies. And there were some questions on how does this new disease construct impact what I submit for insurance. What the AAP responded was that insurance companies don't reimburse based on severity of disease. They have their own requirements that they are basically free to make based on their scientists. So I looked up the updated Delta Dental handbook that I used to have to deal with a lot, and I looked for any numerical values recommended for covering scaling root planing, and I didn't find any. All they say is it will be denied if it does not have radiographs, probing depths, and proof of clinical attachment loss. Some more changes are that we're no longer treating aggressive and chronic periodontitis as separate disease. We are going to apply a stage and grading system that can be adapted over time as new evidence emerges. So here's one of our most important models that we're going to keep coming back to. A patient is going to fall somewhere on this model at every stage in their life. It's accepted that a patient will progress from some level of gingival health to gingivitis, and that gingivitis is reversible. It's inflammation without the loss of attachment. So patients can go back and forth between these two states. However, once a patient progresses beyond gingivitis, there is no turning back. So a periodontitis patient is a periodontitis patient for life. They will require varied treatments, and the goal of the therapy is to stop the progression of the disease and obtain a stable case of periodontal. The authors of the report divided everything into 4 categories of conditions, and we will go through a lot of these, but not all. So we're going to skip over a lot of the more rare diseases, such as manifestations of systemic disease or the rare gingival presentations and things like that. But this is our framework for our staging and grading. So on one axis, the stage tells us what the disease severity and complexity is. On the other axis, the grade tells us the evidence or risk of rapid progression, the anticipated treatment response, and effects on systemic health. So every patient will find themselves somewhere on this matrix, and we will apply a definition. There are some modifiers that we will get into as well. So this whole classification was based on the best evidence that we have at this time. However, a lot of our evidence is going to come from expert opinion. So we'll talk about our gingival health patients. What does gingival health and periodontal health look like? No inflammation with an intact periodontium, or no inflammation on a reduced periodontium. So one example would be a reduced periodontium in a non-periodontitis patient. So maybe a patient whose alveolar bone was removed for a crown lengthening case or something like that. More commonly, intact periodontium in a patient with a history of periodontitis, but who is currently stable. So that's how they can be in health. They're still a periodontitis patient. Gingival health on an intact periodontium has no bleeding on probing, no erythema and edema, no symptoms, and no attachment or bone loss. There are also physiological bone levels that can range from 1 to 3 millimeters apical to the CEJ. Our gingivitis patient is inflammation without loss of attachment. It's a reversible condition. Gingivitis will look like erythema and edema, pain, heat, and loss of function. Swelling can manifest as knife-edge gingival margins, and there will be bleeding on probing, redness, and discomfort on gentle probing very commonly. Patient may also report bleeding gums, pain, halitosis, difficulty eating, change in appearance, and reduced oral health-related quality of life. Radiographs do not tell us anything about gingivitis. More commonly, we will see dental plaque-induced gingivitis, either associated just with the biofilm itself alone or mediated by other factors. Systemically, any of these factors can make a patient's response to the biofilm more likely to turn into gingivitis. We're all familiar with these. And in addition, dental plaque-induced gingivitis can be mediated by the local factors we see, such as a restoration margin, oral dryness, and then another category can be a drug-induced gingival enlargement. Next, we'll talk about the periodontitis case. The first step to see if we have periodontitis is screen with very high sensitivity for the presence of perio. The things we'll look for is any marginal bone loss, any interdental clinical attachment loss, and recession greater than 3 millimeters. Once we've identified that the patient has periodontitis, we start to apply staging to classify the severity and extent of the disease, and also to assess the factors that could affect the long-term management. Our first metric is the worst interdental clinical attachment loss in the mouth. Next is radiographic bone loss and tooth loss. So these 4 stages correspond to the degree of attachment loss or to the coronal, the radiographic bone loss or tooth loss. Our complexity involves identifying things like maximum probing depth, vertical defects, and furcation involvement that can make the case more complex to treat. Stage also includes a descriptor as localized, generalized, or molar incisor pattern. Molar incisor pattern we commonly would see in what was termed localized juvenile periodontitis in 1989, or the aggressive periodontitis types, where very commonly the bone loss is restricted to first molars and central incisors. Grading involves indicating the rate of the progression over the patient's life up to this point. How will they respond to therapy and their systemic health considerations. So the nice thing about grading is you just start with grade B, and it's grade B until proven otherwise. We will look at direct evidence of progression. So looking at an old X-ray, an old radiograph and a new radiograph. We'll also look at, if we don't have old radiographs, we can do a calculation of percent bone loss to age. We also look at, do the biofilm deposits, do they seem to match the amount of tissue response, or do we see very thin biofilm but a very vigorous response? Our important grade modifiers come in as smoking and diabetes. Grade B is defined as 10 cigarettes a day, HbA1c less than 7. And so if they cross that threshold, they are into grade C. So once again, severity and complexity, evidence of the rate of progression up to this point, and we will be able to generate our full diagnosis. So in 2019, Canadian Sands published this. It has a lot of really nice flowcharts. So we've been through this already, but we will follow it now through as a flowchart. So one of our key findings is, do we suspect periodontitis or not? So how do we get to that point? We need X-rays that are diagnostic. And if we do see the bone loss, then we strongly suggest suspect periodontitis. If we have interdental attachment loss greater than 3 millimeters, or actually interdental attachment loss at more than 2 teeth, yes. If we have recession or probing depth greater than 3 millimeters, yes, we suspect periodontitis. If we're negative, then we are kind of into the gingivitis and borderline cases. So now we followed our flowchart to identifying that our patient has periodontitis. We need to start making sure that, is the periodontitis due to some of these other factors? So that would not be like our traditional disease model of periodontitis. So then they would go back to, no, they're not actually a perio case. If our findings are caused by these items. If we have no local factors and we have clinical attachment loss on greater than 1 non-adjacent tooth, then we have periodontitis. So then we would do our comprehensive perio exam with our periodontal charting, radiographs, and then we can kind of go confirm or deny that it's a periodontitis. We had our suspicion that it was perio, but he didn't have any 4 millimeter probing depths. It's probably more like a gingivitis type case. Periodontal probing depth 4 millimeters or more, yes, it's periodontal case, and we need to do our staging and grading. This flowchart is very extensive, but what it's going to do is help us get to our descriptors. So first we'll get our extent, so is it localized or generalized? Then we'll get to our stage 3 or 4 or stage 1 and 2. So the difference between 1 and 2 and 3 and 4 is kind of between moderate versus severe disease. So that's how you kind of start thinking. Basically, all of the requirements that put us into stage 3 or 4 we have gone over from the table, and they're located here. So it's things like a probing depth greater than 5, then we're there. And then to get to 4, there's some other factors. Stage 1 and 2 would be more like no no tooth loss from perio disease, and based on the level of attachment loss, they're either stage 1 or stage 2. Our grading is a little bit more straightforward, and oftentimes it's going to rely on our calculation of bone loss per age, because we oftentimes don't have serial radiographs going all the way back. If we do, then we can estimate the disease progression and get a really accurate number. But we can do a simple calculation of the millimeters of bone loss over the age of the patient. And in grade B periodontitis, it's from the range of 0.25 to 1. In grade C, it's greater than 1. So that means if there's 50% bone loss and the patient is 50, then their calculation is 1, so they're grade B. If there's 50% bone loss and the patient is younger than 50, they're greater than 1 ratio, and they are grade C. I hope that makes sense. So after we've established our grade, we will do our grade modifiers based on diabetes control and based on smoking amount. Once again, here's our staging. Here's our grading. These materials are available on the AAP website for free download. And here's our matrix. So we're going to apply this to a case, and I feel that it's more interesting if we apply it to kind of a unique case rather than a very common type of presentation. So we'll imagine that we have a new patient, and these are their radiographs that we're looking at back in our office. So let's say we're sent this radiograph, which is current. Do we suspect periodontitis? Yes, because we can see there's attachment loss on more than 1 non-adjacent tooth. So for example, there's attachment loss on number 19 distal. There's a lot of attachment loss on canine and premolar, and there's attachment loss on this molar as well in here. Now we do our interview, and we learn that this patient is only 30 years old, and she has no systemic illnesses, no known genetic diseases. She recently gave birth to a child but has no other medical concerns. And she reports that her missing mandibular incisors were getting progressively more mobile and were extracted, she was told, due to gum disease. So we will next go look in the patient's mouth, and we'll do our periodontal charting. what we will find initially is multiple missing teeth, multiple teeth with probing depth 6 millimeters and above, and measuring from the CEJ to the base of attachment, clinical attachment loss of 10 millimeters. So already, we already know she's at least stage 3. To be stage 4, we need to have to look at some of the other factors. So the factors in this case for stage 4 would be, in addition to stage 3, need for complex rehab due to these things. One of the most common ones would be the ridge defect or the bite collapse, drifting, flaring. So she clearly has drifting and flaring of her teeth, and she's getting close to having less than 20 remaining teeth or less than 10 opposing pairs of teeth. So based on those criteria, she is a stage 4 patient. 5 or more teeth lost to perio disease, and the extent distribution, we could look at 30% in teeth involved, or we could say generalized, but they do have this molar incisor pattern. So typically it's maxillary central incisors, but because we see it on molars and incisors in the mandible, I'm calling her molar incisor distribution. So for grade, we have to assume grade B until proven otherwise. And I don't have any old radiographs for her, so I have to do the attachment loss per age. She's 30 years old. This bite wing doesn't show the apex, but we can say that there is greater than 50% attachment loss if we started around 1 millimeter from the CEJ gone to here. So she has, let's say, 50% attachment loss at this, the worst site. She would then have greater than 1 millimeter bone loss per year, and so she would be grade C. Another way to kind of think about that is this diagram. So an 80-year-old patient who had grade B, they would have 80% of their bone missing. If they had more than that down here, they're now grade C. If they have less than that, they are now grade A. So any other criteria that might put her into grade C? Well, there actually is. She has destruction that's more than I would expect based on the plaque and calculus. So the destruction is not commensurate. The destruction exceeds what I would expect. There's not a lot of biofilm, but she has a lot of destruction. This is an indicator of rapid progression or early onset disease. So here's kind of my photo. She does have plaque, but it's not really heavy, and there was no calculus because she's been in treatment for periodontal disease. She's not a smoker, not an uncontrolled diabetic, but still she's firmly in grade C. And so she is periodontitis, stage 4, grade C, molar incisor distribution with no grade modifiers. So that would be the diagnosis that, we would document maybe if we were doing clinical studies in periodontology, or we were using the updated classification. So why don't we have aggressive anymore? So based on the current evidence, actually, the presentations are not different diseases. They would have to have a different etiology and a different pathophysiology. And so what that means is the mechanism by which the bone is destroyed would have to be different. And we have a lot of research that shows it's really not the same. It really is the same. There's variations in clinical presentation, but that doesn't mean that they are different diseases. Because a substantial variation exists, there are probably population subsets with distinct disease trajectories due to differences in exposure and or susceptibility. So those are some of our factors that we're starting to get more data about, such as specific gene mutations or genes. It can also be specific bacterial populations. So I'm going to move from periodontitis to broadly gingival recession or mucogingival issues. So those fall under the third category, developmental and acquired conditions, mucogingival deformities and conditions. In that category, we also have systemic diseases that affect the periodontal supporting tissue. So one of those most common ones is diabetes. We'll talk about that. There's no characteristic phenotype for diabetes periodontitis patient. It's not a distinct disease from periodontitis, but it is an important modifying factor. The level of glycemic control in diabetes influences the grading of periodontitis, as we know. Obesity has been shown to be complex, but to have some relationships with periodontitis, significant positive associations, although obesity is involved with many other diseases. The overall effect appears to be modest, however. Rheumatoid arthritis found an association between rheumatoid arthritis and periodontitis, and there's some evidence that periodontitis may cause rheumatoid arthritis to be more pathogenic. Smoking has a major adverse effect on the periodontal supporting tissues, increasing the risk of periodontitis by 2 to 5-fold. But there's no unique periodontal phenotype features of periodontitis in smokers. It's an important modifying factor, and as such, it's found in the grade. So recession is defined as an apical shift of gingival margin associated with clinical attachment loss. The possible consequences of recession, as we well know, include impaired aesthetics, dentin hypersensitivity, and non-carious cervical lesions, or root caries. The gingival phenotype definitely has an effect on the development of gingival recession. The combination of the soft tissue and the bone tissue make up the periodontal phenotype. The phenotype can change through time depending on environmental factors and clinical intervention. Thin phenotype definitely increases the risk of gingival recession. However, there have been case reports of very thin gingiva being stable over many years. How can the periodontal phenotype be assessed in a standardized and reproducible way? We can say if a probe can be seen through the tissue, then the tissue is thin gingiva. How much gingiva do we need for periodontal health? The consensus statement was that any amount of gingiva can be enough to maintain periodontal health when optimal hygiene is attainable. Some studies reported a positive association with toothbrushing and recession, others did not. Restoration margin can affect the development of gingival recession, particularly when we have a thin periodontal phenotype. Thank you. So this is the Miller classification that's based mostly on the interdental tissues and the mucogingival junction. And it was designed to kind of give a prognosis for how predictable root coverage is. The RT classification was recently proposed. It uses interproximal attachment loss compared to the buccal soft tissue level to say a little bit more about the condition and prognosis. So recession type 1 is no interproximal loss. The CEJ is not detectable at both aspects of the tooth. If there's RT type 2, there is some loss of interproximal attachment, but the interproximal attachment loss is less than the buccal attachment loss. And in type 3, the interproximal attachment loss is higher than the buccal attachment loss. So we'll kind of apply that to some real world cases. What would we define as gingival recession? It has apical shift of gingival margin. There's a lot of other things that are very relevant. So is the interdental attachment level normal? Is the tissue thin or thick? What's the condition of the root? Can we detect the CEJ? What's the position of the tooth in relation to the alveolus? Is there a frenum involvement or adjacent recessions on other teeth? And so as a common theme, we're not satisfied with one kind of axis of classification. We added second axis and we create a matrix. So we will classify our patient based on the RT type, and then we'll kind of fill in these areas in terms of what's the depth of the recession. So how many millimeters of recession? What's the thickness? What's the width of the keratinized tissue? Is the CEJ detectable or not? Is there a root surface concavity, so a step between the root and the, well, at the location of the gingiva? And we'll fill those in on some cases. How do we identify the mucogingival junction? There's several ways. This shows a photo of a patient that I stained with an iodine solution. So the gingiva will not stain. And then another method is to take the tip of a perio probe and move the tissue side to side and see if it feels bound down or not. Then you can make your measurement and determine what's your width of keratinized gingiva. Okay, so here's our recession case. So first we need to see RT1, 2, or 3. So remember, RT1 is the only one that doesn't have any interproximal attachment loss. Do we think we have interproximal attachment loss? I don't think so, because everything is really filled in. So we are RT1. What's the depth of recession? We just measure that with the periodontal probe. Phenotype is one, gingival thickness can be subjective, but I'm calling it thin here. Particularly in the mid-root areas. There's only 1 millimeter keratinous tissue, and the CJ can be detectable, but there is a significant step. Here's another RT classification type. So for RT, remember we're looking at interproximal, so there's clearly been some interproximal attachment loss. But is the level of the interproximal tissue above the level of the mid-buccal tissue? Yes. So we are RT2. And then we can measure, and in this case, we're calling it a thick phenotype with non-detectable CEJ. Maybe the CEJ is here, I don't know for sure. So this is a way to gather all the information about a presentation and kind of decide what to do. And in this case, I treated this with a classic periodontal procedure, free gingival graft. I was able to get a little bit of root coverage, but most importantly, I was able to create a band of attached keratinized gingiva for the patient. So we're going to discuss some of the other conditions that we find. One is altered passive eruption. Basically, it's abnormal dento-alveolar relationships. So what does that mean? The gingival margin, and sometimes the bone, is more coronal than it should be. So you either have pseudopockets or you have gum covering enamel and aesthetic concerns. This can be accomplished surgically. This can be corrected surgically. So here's a case of altered passive eruption. And here's a classification system. So again, we're not content saying altered passive eruption or not. We're also saying type 1 or 2 based on how much keratinized tissue is present. And that's presented by these authors. So I do think that's a very relevant finding. Focusing on the left column, altered passive eruption presents with gingiva over the enamel, but bone at a pretty much normal level, okay? Altered active eruption has gingiva over the enamel, but bone too close to the cemento-enamel junction. So how do we determine whether or not it's altered active eruption or altered passive? We have to numb the patient and sound down to bone and identify where the level of the bone is. So this is an important way to classify a patient if you are embarking on crown lengthening of a case like this to obtain a more harmonious tooth form. You need to know, you need to plan before your surgery whether you're removing bone or not. And also, if you have too much gum, you can either cut away the gingiva or you can place it down apically. The type 2 situation is where you're more comfortable cutting away some keratinized gingiva because you have more. I'm sorry, type 1. So type 2, if you cut that away, then you're left with a lot less. So this is an example of a very elegant classification system for this presentation of altered passive eruption. So talking about the bone levels in relation to the CEJ and the tooth crown brings up biologic width, which comes from a lot of classic periodontal literature. This term is very widely used. So it was defined as the apical coronal dimension of the supracrestal attached tissues. So what they're saying is, instead of calling it some magical width, we're just going to call it what it is, the supracrestal attached tissues. That means everything above the bone that's attached to the tooth. Those are made up of the junctional epithelium and the connective tissue attachment. And so we are replacing biologic with supracrestal tissue attachment. So relating to that, if we infringe on the biologic width, is that a good or a bad thing? It's associated with inflammation and loss of periodontal supporting tissue. And animal studies show that it's also accompanied with an apical shift of the junctional epithelium and the supracrestal connective tissue attachment. And this is talking about if the restoration margin is inside the connective tissue attachment. This isn't talking about hiding the restoration margin under the gingival crest. This is invading the actual connective tissue attachment. Very good. So we're going to move on to our last category, which is peri-implant diseases and conditions, which up to this point, the AAP had not published any type of really criterion of what constitutes peri-implantitis or peri-implant health. And implants are very interesting because the soft tissue around the implants are very different than the soft tissue around teeth. We have lectures about that. One of the main things is the connective tissue doesn't seal as well around an implant as it does around a tooth. So basically, implants are just more susceptible to insult by periodontal disease. So a healthy implant will have tissues with no erythema, bleeding on probing, swelling, or suppuration. So yes, you should probe your implants, and yes, technically, if they're healthy, they should not be bleeding. If it's not possible to define a range of probing depths compatible with health for an implant, because we see so much variation in how deep implants are placed in relation to the soft tissue. So sometimes a lot of our implants will probe 5 or 6 millimeters. And yes, to be honest, many of our implants do have some bleeding on probing. So this is something that's kind of you might say that this state of health is very rare in the real world. But peri-implant health can exist around implants with reduced bone support. So there can be bone loss, there can be exposure of the implant body, but you can have healthy soft tissue. So here's an example of peri-implant health photo that I took of a patient. So he was probing between 3 and 6 millimeters. I'm calling this recession. So I think the lab made a CEJ, maybe there was some recession. And there is not a lot of post-placement remodeling and no bleeding or suppuration. Not really a lot of edema or inflammation, I would say. Maybe a little cyanosis in this case, but not what you would characterize as inflamed. So peri-implant mucositis is very important. The main characteristic of that is bleeding on gentle probing. And I would say excessive bleeding on very light probing or sweeping, when you get all that bleeding, that's a really good indicator of the inflammatory state of the soft tissue. There will be erythema, swelling, and suppuration. Well, there may be. There will sometimes be an increase in probing depth, especially if there is swelling, or especially if there's a lot of inflammation. The probe will probably go almost all the way to the bone, rather than in a healthy tooth where the connective tissue stops the probe. And plaque is the etiologic factor. So peri-implant mucositis, we've kind of defined it as bleeding on probing without bone loss. Can it resolve? Yes, we can resolve it. It may take more than 3 weeks, but if we resolve the plaque, we can usually resolve peri-implant mucositis. The indicators are anything that just predisposes you to plaque accumulation or systemic illness. So ignoring the teeth, implant 12, 13, and 14 were probed. Implant number 12 did have bleeding on probing, and there is inflammation at the tooth there. Obviously, it's affected by this, but peri-implant mucositis. Because despite all that, it seems like the bone has remodeled at a normal level. Peri-implantitis, as we all know, it's bone loss around an implant caused by plaque, inflammation, bleeding on probing and or suppuration, increased probing depths, and recession of the mucosal margin is often commonly seen. So to diagnose it, we need to have bleeding on probing, we need to have increased probing depth, and we have to have bone loss. And both of these factors require a historical, a change over time. If we don't have the change over time, we have to use the next best thing. So we have to use indirect data. We have to use indirect data. We may diagnose peri-implantitis based on bleeding, probing depths greater than 6 millimeters, and bone levels 3 millimeters apical to the implant platform. Here's a clear example of peri-implantitis. We do have serial radiographs, but clearly we've had a lot of bone loss on this implant. Here's another case where the probings range from 3 to 8. There seems to have been over 3 millimeters of bone loss starting from here to here. And we actually might have had some here too. So that's how we diagnose peri-implant mucositis. Okay, moving on to the importance of keratinization. It is very important. So the evidence is equivocal. It appears that keratinized tissue may make it easier for the patient to brush. So here's an example where these implants do not have much keratinized tissue or any keratinized tissue. And you can see plaque accumulation, exposed threads. It's probably uncomfortable for the patient to brush in this area. So we could think about trying to modify the phenotype from a non-keratinized to a keratinized phenotype with a soft tissue grafting, for example, to improve the status of that implant. Ridge deficiencies are very common, and the AAP is calling them peri-implant deficiencies. They occur after the removal of a tooth. Sometimes we can have very large ones due to things like periodontal bone loss, endo, buccal root fractures, thin buccal bone plates, and the position of the tooth in the arch. Also due to the presence of the sinus and medications, and pressure from a removable denture. AAP did not classify edentulous ridge deficiencies, so we continue to use the Siebert classification. Class 1 is defined as a buccolingual loss of tissues. Class 2 is defined as apical coronal loss. And class 3 is probably the most common, with loss of both buccolingual and apical coronal. And we all know what ridge deficiencies look like. So coming to the end, in terms of thinking what's next, is this system useful? Is it going to catch on? With whom? So we have a really cool project that I wanted to talk about with some of my favorite colleagues and faculty at the University of Washington, where the new classification was taught to undergraduate students. And I was involved in this project just by providing photographs, but I really enjoy this project. This new classification was taught to the dental students, and they were asked for what their feedback is. Basically, they said that staging and grading is kind of confusing and difficult. There's a lot of different arrows in the flow charts, so people are getting definitely lost in the flow charts. The concept of direct versus indirect evidence was confusing, especially. So it's, I would say, very rare to actually be able to use direct evidence, because it can just be challenging to track down old radiographs. Doesn't mean we shouldn't try, and oftentimes we can't. Indirect evidence is just a calculation at a certain time based on one tooth, so it's a little bit confusing to some of the students. Also, just the fact that stage 1, 2, 3, 4 is harder to remember than mild, moderate, or severe is kind of an issue. Basically, another thing that's difficult with this is there's a tendency for us to not assign one stage and grade, because we might see different areas of the mouth that have different presentations. But it's really important, we have to say, the patient goes into their stage and grade. It can change over time, but it's based off the worst site in the mouth. So basically, you can't say they're localized stage 1, or you can't say generalized stage 1, but localized stage 4. They would just simply have to be stage 4. So what I took away from this is periodontitis is complex and multifactorial. A two-dimensional framework gives insights on patients who need more treatment or more attention. It can follow the patient for life, and it can adapt to change in their expression of the disease. And especially in research, the framework is very useful. It can be modified and changing over time. So for example, as we find out more about the genetic causes of periodontitis or the histologic causes, we can add some of those risk factors into our existing framework and not have to start over. So I think it's really going to help the research going forward. What we would keep in mind in our clinical practice is the disease can be slow and gradual. It can just kind of die out, or it can be very rapid and it can change. We have to document and treat based not only on what we see today, but also the specific disease trajectory for the patient. So where have they been, where are they headed? And with more patients keeping their teeth and many patients with dental implants, inflammation, pocket formation, and lack of attached gingiva really need to be systematically documented and monitored over time. So if we can use more objective criteria, rather than just saying in the chart note there was generalized inflammation, if we can give as much information as we can, it can really help us, especially knowing that peri-implant mucositis comes right before bone loss on our implant, which nobody wants. With that, I would like to again thank Dr. Hess and all my faculty, co-residents at the University of Washington, and dental colleagues, and I really appreciate this opportunity to share.
Well, thank you very much. We appreciate you spending the time. Perio classification is confusing, and I've watched this twice now, and I don't have it 100%, so it's going to take a little time for me. We've got lots of questions, and unfortunately, these aren't all based on looking at the classification system. It's pretty apparent people know they have a periodontist at the podium here, and they want to ask some perio questions. So, going to hit you with quite a few things here.
Periodontics resident.
Thank you for clarification. As a general dentist, I see patients with furcation involvement, class 2 or 3, where the molar is not mobile. Patients wish to save molars instead of extracting. I find it challenging to know when to extract and when it is prudent to maintain. Any advice there?
Okay. Mobility is one of the most important factors, especially if you're thinking about taking out a tooth today. If the tooth is solid, if you look at the occlusion and it's not in a traumatic occlusion and there's no mobility and there's no symptoms, then we would try to maintain that tooth. Grade 2 and 3 furcations, it depends on the tooth. Grade 2 furcations have been researched very extensively, and there's some authors say it's very predictable to repair those with regeneration. So periodontists can debride the defect and bone graft and membrane and get some new attachment on the tooth, improve the prognosis of that tooth. We talk a lot about prognosis. We have a prognosis system that we use in UW. It's McGuire and Nunn. It's very widely used, and I recommend that. But when you read their publication, one of the things that comes up is prognosis can change. It can get worse or better. And when they applied the prognosis and then they followed the tooth to see if the tooth was extracted, how long, when, they didn't really find that the tooth survival correlated with the prognosis they assigned. And they were assigning prognosis based on things that are very common, like presence of furcation, how much bone loss, mobility. I think coming to mobility is a very key point. So that's a great question.
Okay. Does marijuana smoking affect periodontitis?
Probably in some level, but the research, I would say there's probably more research needed. But there's biological plausibility for several reasons. the heat and the chemicals in the smoke or the vapor. Then we also know, we think the THC can dampen the immune response in some patients. The active ingredient in marijuana, THC, it's a very complex molecule in how it affects the body. So, yes.
Okay. How effective is Arrestin? I've seen research that it is most effective in isolated pockets after attempting scaling and root planing.
Okay, so that's the Arrestin would be a localized delivery of, I believe, minocycline into a periodontal pocket. So the idea and the rationale was, as you described, after scaling and root planing, it can reduce the bacterial load and help healing. I would say that the evidence is, at this time, not very, very strong. We have reviewed material on this, literature on this, and I believe we can go to the AAP publication and find out, but I believe that the consensus statement from the AAP is the evidence does not support it. And interestingly, talking to some insurance companies, they do not have it as a benefit at this time, at least Delta Dental. But maybe they did in the past, and I think maybe the research has not borne out really the results that they would need to pay for it. I personally have not used it. So there is research out there.
You talked about smoking negatively affecting periodontal structures and contributing to loss. What about chewing tobacco and vaping? How negatively do those tobacco uses modalities after perio compared to smoking?
After perio compared to smoking. We don't have, I would not tell my patients that I know that vaping is any better than smoking, because vaping is very new and very unstudied. Tobacco smoking has been studied for quite some time. So just briefly, the nicotine will constrict the blood vessels. So you may not have as much bleeding or signs of inflammation, but you will have destruction. There's a lot with nicotine that has to do with cell turnover as well. I think it can affect osteoblasts and osteoclasts. So that's how smoking has, but smoking, I think I mentioned, has an odds ratio for periodontitis of 4 or 5. So that's a very good, healthy odds ratio. Vaping is very new, as I said. I really wouldn't be able to tell my patient that it's better. Chewing tobacco, we know about the localized effects it will have on the tissues. You know, we call it frictional keratosis or tobacco keratosis, and we have seen those turn into cancer.
All right, what are your thoughts on lasers for treatment of implantitis?
Great, it's a very hot topic. In my experience, there's a lot of different types of lasers. Okay, so there's things like a CO2 laser or a diode laser that I've used for crown lengthening and gingivectomy in general practice. So you may be talking about that, but you may be talking about some of these other products, like there's a company called Millennium that has a LANAP protocol. I do not do that. I do know a lot of clinicians who do and who have had really good results. I reviewed the studies. The studies a lot of times are from people who are aligned with the company, but that doesn't mean there's anything wrong with the study. One of the things is it's new, so a lot of our studies are small case reports. We just don't have systematic randomized controlled trials where I can say, well, if I do a laser regenerative procedure on one tooth and I do a traditional periodontal surgery on another, the laser is going to heal better. And you're asking about implants. A lot of clinicians do use laser to decontaminate the implant surface. When we're trying to save an implant by doing a surgical debridement, for example, one of the most hard things to do is try and get that implant surface clean, especially because there's threads and it's cylindrical. But a laser is thought by some clinicians to be really good at decontaminating. And there's a lot of other mechanisms that the laser involves, so it can coagulate tissues. It can kind of create a favorable healing. Patient-reported outcomes are becoming much more important to our evaluation of our care. So, maybe later on in the future, we will have studies that say, the result was about the same, but the patient outcome, pain was better. And so that's why I'm going to recommend it for you. I don't think we can say that now with a high level of evidence, but these new devices are finding a lot of popularity, and to be honest, I think it's worth looking into. That they are a significant investment.
Yeah, absolutely. Depending. Yeah. If you have recession due to orthodontics but healthy tissue, are you a periodontal patient?
No. So you would be gingival deformity in the form of recession. So for periodontitis case, we need to see interdental attachment loss, so like interproximal attachment loss on more than two non-adjacent teeth. So no.
Okay, thank you. Is there evidence to suggest that probing around implants can cause adverse effects such as severing fragile connective tissue attachment or scratching the implant surface?
I would say there probably is evidence. I've seen photographs of implants that have been scratched by curettes. Probe's a little different than a curette. Plastic probes, well, I'll just say, what we happen to use at the UW, we don't use plastic probes on our implants. We probe our implants with metal probes. We're not trying to scratch up the surface. We are going to be, as you say, penetrating most of that connective tissue because it's so fragile in an implant. But we're not really doing that circumferentially, and I think we should know where the probe stops. That's our indication of where the bone level is. On a radiograph, we can get a great approximation of the mesial and distal bone height, but we don't know where our buccal bone level is unless we use other methods. That's a topic up for debate as well.
Okay. And so you just don't have a preference in for plastic probes or metal probes then?
I feel that I probe gently enough that I'm not really going to mar the surface of, because the implant surface, there's a lot of different things. So you could scratch the healing, or you could scratch the abutment, but once you're on the implant body, it's titanium oxide. So I don't think a rounded periodontal probe is necessarily going to scratch it up too much. And so I feel like a plastic probe might work just as well. Yeah.
Yeah. Okay, I'm just going to reiterate this. I've typed this in the chat feature there, that if you have a question or a similar question to somebody, just use the upvote thumbs up and it'll move it up, because we've got 40 questions here. And let's just get to the ones that most people want to hear about. So, okay, we have do you have the link for the access to that flow chart that you showed?
Goodness, yeah, I see a lot of people are looking for the flow charts and the links. I received them by email from perio.org, but I'm a student member. Yeah, I was pretty sure I was able to find them. If you go to the AAP website, there should be a section that's like press releases or educational materials. But these are out there. These publications that I referenced, yeah, they are coming out of the JOP and the Journal of Clinical Periodontitis.
Thank you. With this classification system, is it possible to go from stage 3 to stage 2 with the removal of a problematic tooth?
Saw that question. We just have to pull up the staging and grading and see, but I think if we're saying they're stage 3, yeah, I think it's possible. If the only perio condition in the mouth that put them in stage 3 was on that single tooth, then they could. So yes, patients can change. They can change their stage and grade over time.
All righty. Could you give a recommendation for a patient at-home use of perio mouth rinse?
Geez. Just for like a maintenance, like obviously I like to use chlorhexidine after scaling root planing, maybe for a week at most. So make sure that they're not taking that routinely. I would think there's a lot of different ingredients to look out for when we take our pathology. Sodium lauryl sulfate is associated with aphthous ulcers. So you might want to stay away from that. You might want to stay away from alcohol because that's going to be drying. To recommend a good one, I don't really know what to say. I know there's a lot out there. A lot of my patients, some of my patients have come to me and they said, this is what I like, and I've always used it. So that's what I would stay away from.
Okay. For initial screening documentation, is a PSR acceptable?
Right. So periodontal screening, something. So it's a way to more quickly identify the status. And I would say that's a great way to get your mind thinking, do I have a perio case or not? I believe PSR it involves kind of probing 1 or 2 teeth in each quadrant. So obviously you can do that in a shorter time and then you don't find anything, then maybe you don't need to do your periodontal charting. I would do a full periodontal charting on any of my patients. If I'm going to embark on treatment or I'm going to want all that information. As you saw, we put a lot of information into that chart, and the fact that it's all there together helps a lot.
Well, if I'm referring to you as a resident periodontal student, I would be expecting you to do a full mouth. So you better not be cutting corners.
Oh, me?
Yeah.
No, that's what I said. Is
yeah.
And then when I was in general practice, we, a new patient needs a full perio chart. I worked in public health settings as well, and it's different. PSR was designed for public health, I believe. So there's a lot of different ways to do it. I would want to know all the probings on all the teeth.
Any research on probiotics use in perio health?
Any research? I would say yes, there is research. Probiotics in use on perio health, I don't really, our concept is a concept of dysbiosis. So a healthy person will have these nasty bugs, Porphyromonas gingivalis and AA. We can find them in healthy patients, but it has to do with the healthy bugs are overcome by the unhealthy bugs. And a lot of times that has to do with a host factor that we're still trying to figure out why. So probiotics, healthy bacteria, commensal bacteria is a probiotic. There's not research that I'm really familiar with, I'm sorry.
Okay. At what stage are you recommending scaling and root planing?
At what stage? Not what stage. So when scaling and root planing would come after you've been able to make your periodontal diagnosis. If a patient presents and you are unable to gather your information, so if they have too much calculus or they have too much inflammation and you cannot identify how much attachment loss there is, and you can't identify where the true level of the soft tissue is because everything's just inflamed and puffy, I would not be able to diagnose or recommend scaling and replaning. So I would do some type of debridement and then be able to do a full documentation. I would recommend scaling and replaning if I have, probing depths greater than 4 millimeters, and if I detect any root surface that is, that has calculus or that needs to be instrumented to become smooth. So sometimes that means scaling and replaning needs to be done multiple times. Okay, so that's a tough question. Basically, I would want to scale replane any root that needs to be instrumented. So sometimes, it doesn't even get done in the first 4 quads. But scaling and replaning, it's not necessary, to do scaling and replaning, you really have to be sure you have a perio case. Because I've had patients where they came in for their first visit, I was getting 4 or 5 millimeter probing depths. Maybe I saw some bone loss and tons of bleeding, but I don't think scaling and replaning is necessarily the right choice because they didn't have calculus or rough root surfaces. So in that case, sometimes a debridement, oral hygiene instruction, maybe other modifications, you can obtain periodontal health.
Do you have any information about stem cell research for treatment of periodontal disease?
Yes, I've reviewed numerous papers. Stem cell research is a promising area. Particularly, we can take, there has been researchers that take stem cells and place them into a bony defect, so like a scaffold of tissue, and the host cells can kind of grow. So periodontal ligament cells are also a source of stem cells. So the research is out there. I don't know of a lot of in vivo studies. Mostly it's lab studies.
Okay. There's lots of questions about lasers. I think you've answered what you know about lasers, unless you want to expand on anything.
I would recommend, if you're interested, to kind of find the publications that these companies are referencing and read them for yourself. And if you're interested, to take their course and decide if you want to do it or not. It's, it's a hot topic. There's lots to be said. There's lots of people that love them. There's people who think there's no evidence and it's just all, just not supported by the evidence. And the insurance companies as well, a lot of them are not really picking up. They're not saying that it's supported by the evidence. Some are, some aren't. So I would.
Okay. How do you feel about protect trays for, treating perio disease?
I'm not super familiar with PerioProtect trays. Is that, I know, yeah, I'm not familiar with what that is.
I think it's a tray that comes and it's got the medication in the tray, and you use it like kind of a disposable bleaching type thing. So yeah, if you're not familiar with it, I guess you're not going to be able to answer that. If there is an abfraction or filling on the CEJ area, how are you taking the recession level?
Great question. So if there's an abfraction, and you could just use the most coronal part of the abfraction and say that's where the CEJ was. You could look at adjacent teeth, so you could go off that. So you could just hold your probe horizontally from the CEJ of the adjacent teeth and make that your landmark on your tooth that you're measuring, and then just lay your probe there and measure. But that's a great question, because like we, in the new classification, whether or not we can detect the CEJ is important.
What are your thoughts on glycine powder and air polishers for implants?
Oh, good. So that's a great way to, I think, decontaminate an implant with or without surgical access. I think decontaminating an implant by, at a periodontal maintenance or a scaling root planning appointment, it's hard because If you're just sticking a curette in there, you really don't know what you're doing. I do believe the evidence supports this, and I have used the air polish at University of Washington, the grad perio clinic, and I've seen some good results. It seems like it's a way to remove biofilm, maybe a little bit better than traditional. Yeah.
Okay. Is there any new research on treatment modalities concerning building 4+ millimeters vertical bone height or correcting large vertical defects?
Yes. This questioner, he should read some of the publications by Urban, U-R-B-A-N. He has pushed the boundaries of vertical augmentation, and I would say he has shown some very remarkable vertical augmentation. That being said, it's advanced surgical procedures. A lot of times, probably if we are seeing a severe vertical defect, 4 millimeters or more, we are probably not expecting to get a lot. So it's easier to build the horizontal bone. If we have a vertical defect and there's a peak of bone on either side of the defect, then we can draw a line from where that existing bone is, and we can, I myself would say, I think I can get that much vertical. I'm not as von Urban, so, it's kind of a unicorn, but there's been a lot of really cool stuff presented. So if you search the literature for that question and many others, you will find some answers. Yeah.
Yeah. It's just tough. As a resident, you have a real advantage being able to access the library system here at the university, and it's tough for the average practitioner sometimes to get their hands on these papers. And
that's a really good point. Yeah. Up here in my ivory tower with all my.
It's exactly with all those degrees on the back on the wall there. All righty. At what point do we consider a tooth as non-restorable, needs to be extracted?
Okay. Big question. So with periodontal prognosis, we wouldn't say non-restorable. We'd say the perioprognosis is hopeless, and the tooth should be removed. And so usually periodontally, that's a lot of mobility that we don't think is going to be, maintained. More than 50% attachment loss, grade 3 furcations. We start thinking seriously about removing a tooth for perio. But if you're saying the tooth's non-restorable, that's a restorative question, which is fine. But a lot of my criteria involved, what's the crown root ratio going to be if I have to crown lengthen this tooth? What are we going to end up with? How much Faribault there is? So yeah, tooth extraction, we're going to be faced with this decision every day. You can't really just plug a tooth into a flow chart. You have to talk to your patient. And some patients will say, I want to try everything I can to keep this tooth, even if it's for another 2 years. Some will kind of really, want that tooth out just because that's kind of how they're functioning at this time.
Okay. If a patient is a grade C with smoking as a grade modifier, then the patient stops smoking. How does this alter their grade?
Great question. I think you just have to look at the other criteria for that. So if they were grade C, let me just pull up the table. Is that being shown?
Yes, it is.
So non-smoker, by that modifier, it's grade A, but then you would still fall back on your tooth, your bone loss calculation, your radiographic, so your evidence of progression. So if the only thing that put them into grade C or B was the cigarettes, and now they're here, yes, they're back to grade A.
And again, can you talk about that bone loss calculation? How's that ratio? How do we do that again?
Very good, sure, yeah. So it's based on the patient's age and the amount of bone loss you see on the radiograph. So grade B is based off of a ratio of 1. So if you were a 80-year-old patient and you followed the trajectory of grade B, just with grade B periodontitis, you would end up with 80% bone loss. So to do some more example calculations, I can pull up one of these. Yeah. So I simplify the calculation. I just say, is the percent bone loss over the age greater than 1? Okay, so look at the radiograph, determine percent bone loss on the worst tooth. Divide that by the patient's age. You'll get a number. So if they had more bone loss than their age, they would be a grade C. They'd be more high risk.
Okay. All righty. Lots of people asking for slides and that kind of stuff. I think we'll try and figure that out after the fact there. You know, that's not very practical to get the PowerPoints out now. We'll figure something out.
I do have something, Dr. Hess.
Yes.
I can maybe put up really quick here if I can find it. Jessica Latimer at the UW, she made the module that the dental students used to learn. And it has a lot of the flow charts and
terrific.
diagnoses. And she has given me permission to share that link with everybody.
Beautiful.
And I'm just going to look for it really quick here.
Yeah, if you want to put it in chat. And Miss Latimer is going to be one of our participants in our Howard competition this Friday, with the WAGD, and that's her presentation there. Exactly.
Right. So I'm going to pull that up in just a sec, Dr. Hess, and just look at that.
And again, thank you for everybody that's joined us on this presentation today. You're going to be receiving an hour and a half of CE credit, and that'll be coming from the University of Washington CE. For those of you that have asked the question again, where can you view this presentation? It will be on YouTube. You just simply go to YouTube and type in Washington Academy of General Dentistry, and you'll be able to find the webinars that are there. If you like, subscribe, and check the bell that's there, you'll be notified as new webinars are uploaded. For instance, Dr. Michael Fling's webinar is now uploaded, I believe. So those of you that want to review that again, it's on the YouTube site. Sorry to interrupt you there.
Okay, no problem, Dr. Hess. So this is the module that was created, and it is open to the public. As far as I know, just to understand, you're not going to be graded or anything like that. But Jessica put this together. It has a lot of the flow charts that people are asking for, and I believe the charts that have staging and grading from AAP are available somewhere on their website. And another thought I had with some of these questions on what to do, whether to extract if it has a furcation, consult with your periodontist, and they will be very helpful. You know, even just send an X-ray, talk about is it mobile or not. You know, we're here for you guys. So we're just a phone call away. I hope that presenting this new classification that might be a little foreign. I don't want it to seem like everyone needs to start using this tomorrow. In fact, I don't expect most people at all to use it, but I do think in 20 years, the perio literature will have benefited really greatly from this. And I do think that it's getting us thinking about who are these red flag patients in our perio programs, the smokers or the people who don't respond normally to treatment. Now, obviously, you know, those patients also, you know, a periodontist can be very helpful in managing those patients. So maybe it can be an identifier on when to make a referral. But I do think that if we look into it, we can kind of see a little more about how the disease works rather than just saying you're either moderate, mild, moderate, severe.
Okay, along those lines about which classification system, obviously you've worked in private practice in Washington State here, and as a general dentist, now I've got to be submitting my claims to Delta and Primera and all the rest. What systems are we supposed to be using, or do you know still, because you've been out of that side for a while?
Sorry, with insurance companies, I believe Delta Dental uses the ADA case types. And I believe they want us to have some type of diagnosis, such as generalized chronic periodontitis. So use the existing ADA case type or the Armitage 1999.
Okay.
And I thought that with the perio class, if you just type anything into your identifier, it'll let you go through. So I'm going to try that. So for me, when I just type anything into that identifier thing, it works, everybody.
Okay, terrific.
Maybe I can test that. Well, so can we see if it's working? All right, great. And thank you very much to Jessica.
Thank you very much for guiding us that way. So.
Absolutely.
Okay, well, we're at 4:10 here. You can see the Q&A. Is there any questions there you want to tackle before we let you go here today?
There's a lot of great questions, Dr. Hess, from the audience. I'm really enjoying it. A question about difference between cement versus screw retained in peri-implant mucositis. There is evidence that cement, if a cement retained crown is placed and cement goes under the tissues or onto the implant surface, that implant will have cement instead of bone attached to it. And then we've seen a lot of cases of peri-implantitis from cement. So, but then when we look at the systematic reviews, they compare failure rates or bone loss rates. What we find, just very generally from what I reviewed so far, screw retained implants had a higher mechanical failure rate. And I believe cement and screw retained implants did not have any real great differences in the amount of bone loss.
Yeah, it's very interesting that that's in the literature, yet personal experience for myself has said screw retained I've had less issues with. So anyways, we could talk all day about peri-implantitis and residual excess cement. So I think we'll leave it at that. Thank you very much for spending time with us. Yeah, I'll let you stop sharing your screen, and I'm going to put our PowerPoint up again with the information of upcoming webinars. Looking forward to having you present for us sometime in the future or at the Washington Academy of General Dentistry, the Master Track program. You'll see that we've added some additional webinars here today, different than what you were seeing go by earlier in the day. Don't forget that Dr. Yassine and Dr. Catafucci are getting together April 29th for the Implant Study Club, and they're going to be talking about immediate implants. So that's a good one. It's been a good series. Dr. Ann is going to do a webinar on intraoral scanning. I saw this at the Academy of Operative Dentistry. Best intraoral scanning lecture I've ever seen. Hey, we're continuing with Omni and Leadership Through Crisis. We've got quite the panel coming up on Thursday. And don't forget the Canadian Academy of Restorative Dentistry has their Card P Day, and we've got 3 speakers from the Canadian Academy of Restorative Dentistry and Prosthodontics coming up. Just confirmed that the Arkansas Academy of General Dentistry will be providing us with some speakers as well. So they're putting their trio together. So we've got lots of webinars coming up over the next couple of weeks. Depending on what happens here in Washington State, if we go back May 18th, we'll be tapering down these webinars. If things should change, we will continue to try and bring you CE seminars at free seminars, and we appreciate you spending time with us. Again, the Washington Academy of General Dentistry, Stay Home, Stay Healthy, CE. We want you to, enjoy the seminars we're doing. You have access to them. And if you have any ideas of somebody that you'd like to see speak, you can email us at info@washingtonagd.org. And with that, I just want to thank our supporting staff, our executive director, Valerie Bartoli, our panelist, Dr. Gary Hayamoto, and I'd like to thank our webinar or our website monitoring person, that's Dr. Pressett. So thank you, Dr. Pressett, for getting these details up on the website as soon as possible. Any other questions? You've got that info@washingtonagd.org. And please follow us on Facebook and follow us on our YouTube channel as well. Dr. Giardino, thank you, sir. And we look forward to spending time with you in the future.
Thank you, Dr. Hess, and thanks for everyone who had the questions and for listening. I really enjoyed it.
All righty. Thank you, Valerie. I think we can just give it a couple more seconds here and let a couple more of the flyers go through, and then we'll just log off for today.
Okay, will do. Thank you, Dr. Hess. Thank you, Dr. Hayamoto, and thank you, Dr. Michael.
Thank you, everyone. Just trying to type a response to Brittany Dean there.
Oh, yeah. Oh, sorry. Yeah. It